All right, hello everyone. I wanted to send out the recorded version of the week 4 content for live class. Because week 4 is a test week, you're getting this as a recording because we don't have time for class because of that test. I'd like to remind everyone that for most of you, you've taken your exam by now. This is the perfect time to just take a little bit of time for yourself, even if it's a small amount. So find whatever it is that you like to do to de-stress, so that you can start fresh for this next section on this next unit test. So don't forget to take that time, relax a little bit. I know you've got a lot on your plate, but have a little bit of time for you in whatever way it is that whatever you like to do best. All right, so let's jump into the content for this week. It is chapter 18, Budgeting Basics. It's a great chapter because it's really kind of concise and I think a little bit more black and white than some of the other topics that we cover. Okay. We generally have some great definitions that help us to understand the content, and this week is no different. Budget itself is a financial plan. It's the actual plan that specifically looks at the allocation of the organization's funds and a control for ensuring that results comply with the plan. So it's looking at the actual identification of what's going to happen over the next year and how we're going to meet those goals that we have over that next year. It's a black and white document. The budget assumptions, kind of a tricky topic here. Assumptions, these are statements that reflect issues affecting the future performance of the organization. You use them as you start to plan the budget. So they're used as a framework for developing the budget. Budget assumptions address questions like these. Are supply prices likely to increase or decrease? What salary range will ensure that the organization is able to recruit and retain quality employees? What are the competitors offering in terms of new services? Is patient census likely to increase or decrease? So it's a series of answers to questions that would help you to determine what the needs are for the budget over the next year. And those are called budget assumptions. And we need to use them as we help to set up the budget. And then capital expenditures, these are dollar amounts that are spent on items that would have long-term value to an organization. So typically including buildings, equipment, these are big dollar items. We're going to talk at length about examples related to them, but capital expenditures. Expenses are just that, dollars that are going out, right? Many of us understand that. An event or an item that requires the outlay of money for the purchase or the occurrence of an obligation for future payment. Major expenses for healthcare organizations can include things like employee salaries, medical supplies, equipment, and facility maintenance. Salary is one of the big ones for us. A fiscal year is a 12-month period calculated annually. The fiscal year does not have to constitute the calendar year. So your organization gets to determine what a fiscal year is for them. So though it is a 12-month period, it can really start whenever they say it's going to start. So, we talk about a year that begins in January and ends in December. And your fiscal year might be January to December, or it might start in August through July, potentially starting in July. So it's just whatever your organization uses. If you're part of a chain hospital, then that chain hospital generally all use the same fiscal year. A full-time equivalent is the number of hours worked or paid that is equal to that expected of a full-time employee working a 40-hour week. So annual work hours for one FTE equal it's 2,080 hours, and then monthly work hours equal 173.33 hours you see on there. One FTE may be occupied by one employee working full-time or shared by two employees. So you can split that FTE into two as long as it still equals that same amount of hours, if they're working part-time. If you've worked in a hospital for a while, you probably have heard that term FTE used in calculation to determine how much we're putting into the nurse staffing. So FTE is really the equivalent of one nurse working full-time hours. Incremental budgeting is a form of budgeting, an approach to budgeting, if you will, that extrapolates from the prior year's budget and adjusts for future growth or a decline in revenues. So if you're doing an approach that is called incremental, you are using last year's budget and then working from that budget to make adjustments for this year's budget. And we're going to compare that zero-based budgeting, and we'll talk about that one in a minute. Revenue is money the healthcare organization receives. It's what is planned to come into the organization, and we're providing healthcare or related services through normal business activities. So it's synonymous with income. Salaries, wages, and benefits, also known as SWB, is a budget category that typically includes direct payments for hours worked, bonuses accrued, paid time off, health benefits. We don't always think about that. Our health benefits go into that pot with salaries, and the employer portion of payroll taxes and workers' compensation as well. All that rolls up into SWB. Supplies are materials used in performing our tasks within the organization, typically including clinical disposables, pharmaceuticals, and office supplies. Variance is a great term for us when we're talking about the budget. So we use variance so many times in this course to talk about what is outside of the norm or outside of what is planned. So variance is the difference between the planned budget and the actual results of the budget. Variance analysis then is saying, okay, we're going to look at why there was a difference between what we planned for the budget and what was actually happening. Variance analysis is the process of analyzing the differences in the planned budget results and the actual results. It involves quantitative and qualitative analysis. I love that about it because we're talking about a numerical analysis and a non-numerical analysis. Zero-based budgeting, that's a term, remember, that we are comparing with incremental budgeting if you think about it. So zero-based budgeting is an approach where we begin as though the budget were being prepared for the first time. So we're not taking last year's information and building from it. Instead, we're starting fresh. And there are drawbacks and benefits both to having that form. You guys are probably very aware of budgeting. I'm sure everybody that has a home, everybody that's a student in school, everybody that has a family is probably very aware of how to budget and what budgeting is, because we do that as a student, as a family member, as a head of the household. We do it all the time. So hopefully, some of these concepts are a little familiar to you. Okay, so when we talk about what a budget is, and we looked at the definition of a budget already, it's important for us to know those four basic functions of budgeting. That budget that we talked about is an organization's financial plan that expresses expected expenses and anticipated revenues, what's going out, what's coming in for that 12-month period. Budgeting focuses on predicting expenses and revenues to meet specific organizational goals. So it's important. We already talked about that last time, about the strategic plan and the organizational goals. The budget is built with that in mind. It's monitored and reviewed to ensure that goals are being met. That's important in the year that goes by, because if we didn't monitor the budget, that once we have a variance that comes up, we wouldn't even know it, and we wouldn't know how to fix it. We wouldn't be able to do anything to fix it. So the budget is a document that details how financial resources will be allocated to ensure the organization is able to conduct its business. Because if we don't budget, we won't stay within the means of the organization, and eventually the organization will shut its doors. The budget itemizes the organization's predicted expenses and revenues. A hospital might plan an annual budget to maintain staffing and supplies to operate its current number of beds, perhaps even implement a raise for their staff, open a new outpatient surgical center, for example. Those might just be examples of things that the organization plans for over the year, based on those organizational goals they have, and even based on what took place in the previous year, census-wise or staff member-wise. So remember, this budget has four basic functionings: planning, coordinating, communicating, monitoring progress, and evaluating performance. So let's start with planning. In the planning phase, if you are part of the budgeting process as a nurse manager, and remember, that's your role in this class, you're thinking of yourself as a manager or a leader. You're going to collect information on what needs to be included in the budget, like determining which equipment needs replaced, talking about or calculating staff salaries, and even considering what revenues will be coming into the organization specifically to your area. Remember, we talked about capital expenses and definitions. Many times, nurse managers are asked to determine and submit a capital expenditure form, detailing what capital expenses they would like to include for the next year over the next 12 months. Also, those budget assumptions are very important here because they help they help the nurse manager know what will have an effect on the budget. Those assumptions are used in the planning phase here to help us determine what the budget is going to look like for the next year. So we looked at planning as the most important function of the budgeting process because it really starts it all off. It coordinates and puts in black and white for what is to come over the next 12 months. So very, very important phase. Next, coordinating and communicating is also important for us as a function of budgeting. We don't often think about communicating and coordinating because it's perhaps something that we haven't experienced, and we might do it without even thinking about it, honestly. But imagine if you're a nurse manager and you're trying to create and plan your budget, or even you're in the middle of your 12-year for the budget and you have equipment that fails on you. Well, you're automatically communicating and coordinating with the maintenance people in the hospital. That becomes part of what we have to do for a successful annual year. Even if we're thinking about capital expenses and say, one example of a capital expense is a new bed, for example. Maybe we are planning on changing out the mattresses over the next 12 months or even less on our unit. Maybe we want half of our mattresses changed out over those 12 months as part of our capital expense plan. Or even they've come out with brand new beds that do some fancy stuff that we want, and we've requested new beds for a certain number in our unit over the next 12 months. There's always a new call bell system that gets integrated into the beds, or a new scale or something, a bed alarm that helps us improve quality and outcome and safety for our patients. So maybe those changing out of beds is part of our capital expenses. But we can't do that without the support of the staff in the maintenance department. So maybe you're getting, 6 or 12 new beds or even mattresses delivered to your hospital. They have to go somewhere. The coordination to change them out has to be done somewhere. That simple example of coordinating and communicating is just one of many examples we could give that have to happen to get through a budget year from the aspect or the viewpoint of the nurse manager. So certainly that makes us bring different groups in the organization together, not only to plan the budget, but throughout the budget year, to organize, to discuss resources, to accomplish the goals of the unit and even the organization. With new budgets, a new nurse manager will often allocate resources towards costs that are needed before revenue is generated. We don't even all the time get to see the revenue or how much, is going to be for our particular unit. Maybe you work in the emergency department as a nurse manager. Well, your unit's absolutely creating revenue for the hospital, but many times we don't get to see part of it. Hopefully you do as the role of the nurse manager related to the budget, but sometimes you have to plan without knowing the revenue or, before the revenue even happens. So maybe the facility is planning to do something new, like a stroke center or a chest pain center of excellence, whatever it is. Those dollar items, when you think about it, those are all dollar items. So I don't know if you've ever been through that process before, but it's very expensive for the organization to accomplish this. And so that impacts the budget, and it's something else that has to really be thought about ahead of time. And so sometimes the marketing of what we do or what we plan to do is also a critical piece. It really ties into those budget assumptions. Maybe it's something new we're going to offer in the emergency department. Maybe they're going to bring on an urgent care center as part of the emergency department, and that advertisement has to be written right into the budget as well. So all things to consider. Monitoring progress. So during this phase, the nurse manager adjusts factors to maintain the budget. So remember, we're keeping an eye on it. We've got to monitor it to know if there's a variance at all. And once there is a variance, then we have to take action on it. That variance could be positive or negative. We could go and be ahead of the budget. We could have extra money that we hadn't planned for, or we could have a deficit, right? So the nurse manager has to adjust factors to maintain that budget, potentially adjusting staffing assignments based on census. Maybe the census has dropped lower than expected. Maybe we're talking about COVID, another pandemic, or continued pandemic, another wave of patients, and we have to adjust staff up because of an increased client census. That variance is favorable when the results are better than expected and unfavorable when the results are worse than expected. And then once we have a variance, we have to take it further to do some evaluation of that variance. Sounds like the nursing process. And we'll talk about all of this. Evaluating performance is another important function for the nurse manager when you're looking at a budget, just like the nursing process when we evaluate. The results of a budget can impact a performance review. And so as a nurse manager, you can bet it's going to impact your performance reviews. It can reflect the manager's ability to balance and effectively manage a budget. Nurse managers can effectively manage overtime use, for example, and supply costs, indicating they have control of the budget. That can be a line item on your performance evaluation as well. Nurse managers are often evaluated according to their success in managing overtime, supply use, and many, many, many other things related to the budget. Remember, we're looking for black and white measurable outcomes on performance evaluations. And so whether you are involved in planning the budget or not, you will generally, as a nurse manager, be evaluated on your performance with the budget over that 12-month period. Certainly, the second bullet there is growing trend toward accountability and compliance in the business. Somebody has to be accountable for the budget and the expenditures, and so the nurse manager is a great person to tag with it. There are plenty of types of budgets, I'm sure, but 3 categories or types of budgets that we talk about in this class in your book. The first is the operating budget, which is the overall budget. It allocates funds for daily expenses like salaries, utilities, repairs, maintenance, patient supplies. That's the operating budget. Then there's the labor budget, which is a subset of the operating budget. Because right there where we said allocating funds for daily expenses such as salaries, those salaries are part of the labor budget. This is a subset of the operating budget. Allocating funds for salaries, overtime, benefits, staff development, and training. There's just so much wrapped up into that one little bullet point there. Think about your benefits. It's huge all by itself. A lot of money goes into that labor budget. And then we talked about capital budget already a couple of times. It's the funds for construction projects, lifelong medical equipment, such as cardiac monitors, defibrillators, computer hardware, beds, call bell systems, big dollar items that your organization is going to need, or if they already have, that they need to replace over time. The operational budget then, if we dive down into that a little bit, we see examples of expenses. And these are commonplace: salaries, benefits, paid time off, health insurance, all the things we enjoy. We hardly ever think about something like that until we really have to sit down and look at it in a budget item. Patient care supplies, overhead expenses, utilities, administrative costs, maintenance, and housekeeping. Just some examples of those expenses. And then revenues, remember, those are the dollars coming in. Medicare, Medicaid, private insurance, individual self-pay, grants, charitable or philanthropic donations, all can be revenues that are coming in. In the labor budget, we looked at that a couple of times already, being a subset of the operational budget. The labor budget, which is salaries, wages, benefits, salary rates, overtime benefits, paid time off, health insurance, staff development, training, employee turnover really all fall into that. Typically, this is the largest expense in the operating budget. It's used to provide managers with a productivity metric, if you will, the amount of work produced by a specific amount of resources. And you get a 12-month historical trend for labor hours and patient days to help guide you with this. If you're using an incremental budget, you'll have the 12-month historical trend for labor hours and patient days from the year before as you're planning this budget. The operational aspect of scheduling staff is measured in work hours to meet the needs of patient volume, which is measured by our patient census. So you're talking about work hours and patient census, and that really helps you determine what this portion of the budget for labor is going to look like. Capital budget, again, refers to those big dollar items. It's also called capital expenditures. It's developed separately from the operational budget because these are big dollar items. They are typically taken away from a different pot of money within the organization, kind of a pot they hold aside just for capital budget expenses. And so many times the nurse manager will be asked to provide a list of capital budget items. This doesn't mean you're going to get them. It's kind of like a wish list of big dollar items that's prioritized for your unit. So sometimes it's even organized by section. Maybe you work in a large facility and there's a med-surg section leader who's over 3 or 4 units or wards. And then that person would bring together the capital budgets for that section. The same goes for like a mother-baby suite. That person is in charge of that suite or product line and will gather the capital budget request for that whole area. So again, we want you to think of these as high dollar items. Your organization gets to choose the minimum dollar amount for this. So we're not talking about a small dollar items here. We're not talking about pillows and chairs. We're talking about things that cost at least $500 at a minimum. And your organization might set that minimum at $1,000, meaning that nothing below $1,000 can get requested as part of a budget, capital budget item. Anything below that would go on the supply list or a different list, but not capital budgets. Most organizations usually, in my experience, pick somewhere between $500 to $2,000 as the minimum dollar amount. You can imagine if you're talking about new striker beds, well, you're probably talking about more than $2,000 each. The payments for those items can often be spread out over several years. That's why I gave you that example of replacing all the beds in the unit, because it might happen over multiple years because of expenses of these things. So think of other big items like defibrillators, cardiac monitors that you have in your units. Those are all big ticket capital item expenses. And budget methods. We've talked about incremental and zero-based budgeting already. Incremental budgeting is more commonly used, and that makes sense. You know, it means I've got what I used last year, and I'm going to use that as the basis and go from there. Adjust it as needed. It's simpler to do it that way. If you're a nurse manager, this would be an easier way or easier method to use while getting used to what your organization or unit typically spends or receives. Incremental budgeting provides a forward trend of recent performance with adjustments for future growth or decline in revenue. You take what you already had and adjust it for what you think is going to happen in the next year. Compared to zero-based budgeting, on the other hand, which is used less frequently. It's based on assumptions of no volume and no resources. So you're starting fresh from zero. Resources necessary for 1 unit of service are identified, and then resource allocation is determined on a variable basis tied to the volume. At first glance, zero-based budgeting might not seem like the way to go, especially for a new manager. You probably want to look at last year's budget as you go. But the one great thing about zero-based budgeting is that it doesn't include outdated information because you've started fresh at zero. So that's one positive to it. And then when you're developing a budget, it's a continual process. But as we've already said, planning is the most important step. You need to start it in advance of the fiscal year. While it's an ongoing process and you're going to be adjusting it as you go along, you still need a solid plan before the fiscal year starts. If you get to day one of your fiscal year and you haven't created a budget yet, you'd be at a loss. So you won't want to, be behind the eight ball there. You won't have what you need in place already. Since you're projecting for the 12-month period, you need to start several months before the fiscal year begins. So even though it's continual, it begins with planning, and that planning starts 3 or more months in advance of the fiscal year even beginning. Healthcare organizations usually have a defined procedure in place for budget development. It's routine. Everybody is used to it. That procedure tells managers whether the budget approach will be incremental, zero-based, or possibly some other method. They also define whether you'll use a top-down, participatory, or iterative approach to budgeting. So let's break them down. Top-down approach. This is where upper management sets the budget goals and imposes them on the organization. So the top brass creates the budget and hands it down to you. In the participatory approach, here the nurse manager is involved. So if we're talking about nurses, the nurse manager attends planning meetings, identifies operational expenditures, and has input, though the goals are still developed by upper management. In the participatory approach, the nurse manager gets to participate, like it sounds like, but the goals are developed by upper management. The people responsible for achieving the budget goals are included in the goal setting. The iterative approach is a combination of top-down and participatory. So in this approach, upper management defines their strategic goals, and then the unit leaders develop their own operational budgets to incorporate the individual goals in conjunction with the operations strategic goals. So there's a fine line, a kind of a fuzzy difference between the participatory and the iterative. Remember, in top-down budgeting, upper leadership creates the budget and the goals and then hands it down to the departments. In the participatory budgeting, leadership still sets the goals, but includes managers like the nurse manager in these discussions and planning. And then in the iterative budgeting, it's where upper management develops the goals and then the unit leaders build their own budgets to align with those goals. So those are important to know. Okay. The basic steps for developing a budget. Doesn't it make sense that if you're going to have a role in creating a budget, you need to start by understanding the organization's strategic plan? That includes the goals and the objectives like we had talked about, typically looking out 2 to 5 years and the steps needed to get there. This really forms the foundation of your budget planning. Next, you're going to have to set the budget assumptions. These aren't just set by nurse managers. They're developed collaboratively by individuals who understand, the whole community, the organization, and what's planned for the future. If you're a new nurse manager, your first step in working on a budget should be to review the organization's budgeting guidelines. You need to understand the expectations, the procedures, and the requirements before you create anything at all. And you can't just go off and make a budget on your own. You need to follow those. So once you've reviewed those guidelines, the next step then is to meet with the individuals responsible for the hospital's overall budget. That typically includes people like the chief financial officer or CFO, though titles and responsibilities really can vary within your organization. So that first one there, you need to know the strategic plan and identify goals and objectives. Know the guidelines for your role in creating the budget. You've got to set those budget assumptions. Remember, we talked about those. They are very important as we begin the budgeting process. These should be developed by a team of managers from different departments and areas of expertise, because I'm not the expert in the whole hospital, right? Even if you're the nurse manager that's been there for 5, 6, 7 years, you still are not the expert over the entire hospital. So you're going to bring a team of people or sit down with a team of people to do this, gather information about past results, and then use that information in combining with the budget assumptions to set reasonable expectations for the future. Predict the units of service that will be provided during the budget period. That's very important as well. Remember that, unit of service is us thinking about how we're going to measure our productivity for that unit. And units of service can be different for the emergency department, the med-surg unit versus the ICU. They have very different methods of different units and of service categories or terms because we calculate it or look at that in different ways. If you work in the operating room, your unit of service might be operating room hours compared to patient visits in the emergency department. Project expected revenues based on units of service. Determine expenses for the labor budget first, based on the predicted units of service and the number of full-time equivalents, those FTEs, needed to provide the predicted service volume. Remember, you must have both the FTEs and the unit of service to effectively plan. Whether it's hospital days, operating room hours, or patient visits, those two factors together help build an accurate and functional budget. Each full-time employee is considered that one FTE we talked about, or 2,080 hours per year at 40 hours a week. In some organizations, nurses are scheduled for 3 12-hour shifts, 36 hours per week, or 1,872 hours a year. And each is considered a 0.9 FTE. So your organization might be one of those that considers each full-time RN a 0.9 FTE. So there could be a little bit of difference there, just so you're aware of those. We talked about variances already. We're looking for a difference in what we planned versus what is actually happening in the budget. And once we have a variance, then we have to determine why and fix it, right? So the variance analysis is that process that we look at to determine why there are differences in the budgeted amounts. We do that through comparison of actual financial performance results against expected or budgeted performance. So think about this in your own budget a little bit, what this might look like at home. We're going to use the quantitative and qualitative analysis to look at that variance here. There are just so many different examples of what could cause a variance, a change in employees' salaries, revenues generated, a change in client census, a change in supply usage, and employee benefits, so many different things that could affect or generate a variance, either positive or a negative variance. So really when we're looking at performance, what we're doing is looking at performance over time in this budget. The daily operations for a department or a unit can change in ways that change the budget or make the budget assumptions invalid. So maybe, for example, a unit budgeted for nurse staffing at 5 hours per patient day based on a given patient acuity level. Then the hospital's admission pattern changes and a larger number of patients with significantly higher acuities come in our door. So just the very fact that the acuity, the illness severity of the patient, the amount of work that goes into the care of one patient based on what's going on with them, maybe even their comorbidities, if that changes, then it can affect the assumptions that we had when we helped to create this budget. Qualitative analysis in this explains why current conditions are different than what we had expected. And when we do a qualitative analysis, we're looking at non-numerical analysis. So this could be very subjective. You might, as a nurse manager, for example, call together your charge nurses and say, we're having a difference, a variance in the budget. We're seeing a dollar amount for supplies per week that's drastically increasing over the last 3 weeks. So let's sit down and see if we can come up with some different reasons why you think it's happening. Does anyone have any ideas about what's causing this increase? You will bring together your statistics, your numerical analysis, which is that quantitative analysis. You'll bring that to the table with you. Maybe say, okay, look, here's our census over let's look at a month. The last 4 weeks, of our time here together. We looked at this number of patients, this many number of patient days. However, you're looking at your unit of service, maybe you're working in the OR and looking at how many operating room hours you had. And so you'll look at that quantitative and qualitative together. That quantitative, again, is all the numbers related to the supplies used, the patient days, whatever it is that affected your supplies in this particular example. And then your qualitative is saying, okay, what have we seen? What might have changed? What might have affected the amount of money that we spent on supplies? So those two together, the qualitative and quantitative analysis, that qualitative is really driven towards the assumptions and what's different from the assumptions that we started the budget with. And then that helps us determine why we have a variance at all. And then, of course, we need to make a plan and fix it. What are we going to do to change this variance? Cost concepts related to budgeting. The cost of service in a healthcare setting is usually categorized by factors that affect the overall cost. We'll call those service unit or a unit of service. So we talked about that a little bit already. Direct costs, indirect costs, full cost, fixed costs, and variable costs. They're all really important to know test-wise here. So take note of these. For example, we might be saying, okay, how much does it cost to provide nursing care for one patient for a 12-hour shift? So as you go through that thought process, think about your costs as being the unit of service. Am I working in the OR? Am I working in an ER? Am I working in the med-surg unit? To figure out what that unit of service is for this patient. So that unit of service is the basic measure of the product of service being produced. It's how we measure output of nursing care and the product that we give. The unit of service varies within the healthcare organization and setting, the type of service that's being provided. For example, hospital patient days, home care visits for home health care agencies, patient visits for an outpatient clinic, operating room time for an outpatient surgical center. Those are all examples of a unit of service or of a service unit. Now, the next cost concept is either direct or indirect costs. Direct costs are costs that can be traced directly to the production of the unit of service. So if your unit of service is operating room hours, then these are costs that are related to the care of that patient for an operating room hour. Nursing care and supplies to provide that direct patient care are wrapped right into the direct costs because they are costs that can be traced directly to the production of the unit of service. The important concept is to remember that direct costs vary with the volume of service. So if I'm talking about operating room hours as the unit of service, and I'm looking at direct costs, things that are tied to that patient's direct care, and if my patients decrease, then my direct costs are going to decrease with it because it's tied to that volume of service. The same if it goes up. If my census goes up, then it stands to reason that my direct costs are also going to go up. So as the patient census rises, the need for additional nursing care and supplies is typically also going to increase, tied to that unit of service. Indirect costs are costs that are incurred as a result of the organization's operating expenses, but they aren't directly related to that unit of service. Examples of this can include things like salaries for administrative personnel and the expenses for security, housekeeping, utilities, building maintenance. Your electric bill is a great example. It doesn't matter how many patients you have on that unit, you still have to have electricity for the entire unit. Building maintenance and a security team are indirect costs needed for operations, but not directly related to the unit of, needed for operations, but not directly related to the unit of service provided. And the secretary for the CEO of the hospital, that's an indirect cost. Full costs are the total of all costs associated with the unit of service. Both your direct and indirect costs together equal your full costs. And then fixed versus variable costs. Your fixed costs are costs that do not change as the unit of service volume changes. For example, again, the administrative salaries don't change regardless of the patient census on the nursing unit. The important point about the fixed costs is that they remain steady, regardless of the change in the unit of service. As the unit of service increases, the greater the number to share fixed costs. If your unit of service decreases, the fewer the number to share fixed costs. So your unit of service, again, let's imagine we're working in the OR. My unit of service is operating room hours. So fixed costs are those costs that don't change. Even if my number of operating room hours goes up, my fixed costs don't change. Compared to variable costs, costs that vary directly with the change in the volume of unit of service. For example, in an ambulatory clinic, the cost of immunizations varies directly with the number of patients who receive the immunizations. So variable costs are tied directly with the changes in volume of service. In that example where there was immunizations in an immunization clinic, for example, it's going to make a difference to us how many people come in to get their immunizations, so that number is going to vary. That cost for my immunizations will vary based on how many people showed up, because I don't need to purchase more immunizations if I haven't used my old supply up yet. Variable costs are factors that can vary directly with changes in service, such as cost of supplies that can change based on the market or the needs of the unit. And variable costs would include salary expenses for registered nurses, because that number can change, it's variable. The nurse manager is responsible for improving costs and quality in patient care. It's just one of the main roles. It's really at the heart of being a nurse leader, nurse manager. And so we can do that in a number of ways that we might not even think about. There are probably some of the things on this list you never thought about as important to the way that a nurse manager could improve costs and the quality of care. Ensuring appropriate care planning and proper follow-up to provide resources. Now, I know we think about care planning and how that affects our patients all the time, especially as students, but probably you never tied that to the budget before. But if we can give the proper care planning to our patients and follow-up information, say you're doing discharge education with your patient and you really do a thorough job of discharge education, you answer all their questions, making sure they know when their follow-up appointments are, whether to call or not and make their next appointment. If we do that really well, then probably we're going to see a reduction in patients that return within 30 or 60 days to the hospital, because we've given them all that information that we can give them, and perhaps even done some teaching, teach back with them so that they repeated it back to us and we know that they understood it. Engaging in evidence-based quality improvement projects. This is another great example, because as a nurse manager, if you improve the quality of patient care you give, make that care based on evidence. Maybe you've got some old practices, in the facility. Let's even talk about nursing report. Maybe you typically do nurse station report on patients, but you've implemented evidence-based practice for bedside report, and doing that has led to a reduction in medical errors, reduction in patient falls, increased satisfaction, where you're improving the costs and the quality of care right there. Understanding the staffing budget and how it relates to patient acuity to ensure that appropriate nursing resources are available. Making sure you align that staffing with not only your budget needs, but closely align it with your patient needs. So when there is a decrease in census, that we're appropriately doing the right things with the staffing, either giving them the comp time, sending them home, putting somebody on call, whatever it takes to align with the needs of the patients at that time. Identifying costs. So effective patient care supplies to replace more expensive products and identifying ways to reduce waste is really another important one for us. And sometimes we're running crazy busy all the time as a nurse manager or a nurse leader. And this is a harder one to get, because it's just so important still to identify areas of waste, to replace things that are expensive when we can have something cheaper that still really meets the needs and is quality for our patients. I know it's hard to even think about moving past your bedside role to a nurse manager role, but man, what a critical place, you're in as a nurse leader or a nurse manager when it comes to aligning that budget with the enhanced quality of care that we can provide to our patients. And it's hard to combine the two in your mind and think, how does the budget align with improving care? But it really absolutely does. So if we can make an impact if we can make an impact on, for example, instituting an evidence-based practice program related to something, we can reduce patient falls, for example. We can reduce the 30-day, 60-day, 90-day readmission for our patients. So much of that is in our hands, in our control as nurse managers, and even as bedside nurses as well. Okay, I'm going to stop sharing here, and that is it for content. Remember, I know it's harder to get excited about a chapter when we're not sitting in class together and talking about it, and you're just listening to this, but you have your reading to supplement this as well. And certainly this topic will, of course, be covered in the test review for test 2. Like we talked about at the beginning, please do not forget to de-stress after test number 1. Great job, you guys, getting to that first unit test. Please reach out with any questions. Thank you so much for attending this, and I will see you very soon.